All right. Good morning. Great to have you with us today. We've got a really excellent next hour of information for you on one of the most important health policy issues of 2023, being how quickly states will restore Medicaid to only those who are eligible. During the public health emergency, the Medicaid rolls swelled by about 20 million people, and there are about that many people enrolled in Medicaid who are no longer eligible. We have an excellent panel to share the stories of what their states did to prepare and how the Medicaid eligibility reviews are going. Unfortunately, this issue has been subject to enormous disinformation. Today's session is intended to set the record straight. I am Brian Blaze, president of Paragon Health Institute. Paragon is a health policy research center dedicated to understanding how government health programs are working and developing policies that empower patients and reform government programs. With me from Paragon is Gary Alexander, the director of Paragon's Medicaid and Health Safety Net Initiative. Gary served as Pennsylvania's Secretary of Health and Human Services from 2011 to 2013, and Rhode Island's Secretary of Health and Human Services and Medicaid Director from 2006 to 2011. Gary and I are privileged to be joined by Janet Mann, Arkansas's Deputy Secretary of Health and Medicaid Director, and Kelly Garcia, Director of the Iowa Department of Health and Human Services. Janet and Kelly are in the trenches, and they know more about state Medicaid programs than just about anyone in the country. So it's a privilege to have them here with us today. I'm going to give a brief overview of the reasons why Medicaid enrollment has soared during the pandemic, provide some perspective on the magnitude of the Medicaid eligibility redetermination process that confronts states, and offer some important considerations. Then Janet and Kelly will each take about 10 minutes to share their perspective and the experience of their state. The last half of today's session will be a Q&A with the four of us, and we welcome your questions during that process. You should enter them through the Zoom Q&A feature. I think there are three main reasons why it's important that states only permit those who are eligible to be enrolled in Medicaid. The first is to preserve resources for those who need the program. The second is to preserve resources for other important state priorities, such as education, transportation, and infrastructure. And the third is to reduce improperly spent taxpayer dollars, which mainly benefit insurance companies, which are receiving monthly payments for ineligible people, many of whom have other coverage. The reason that Medicaid enrollment has swelled was because of policies that Congress enacted in March 2020. So at the start of the public health emergency, Congress was concerned about people losing their jobs and losing their health insurance, as well as with states being financially strapped. And what they did was provide states with extra federal Medicaid funding, a 6.2 percentage point increase in the reimbursement that the federal government provides states for Medicaid, on the condition that states not take any steps to remove people from the Medicaid program. This is referred to as the continuous coverage requirement. All states accepted those increased federal funds and did not remove ineligible enrollees for more than 3 years. Late last year, Congress permitted states to begin removing ineligible individuals from the Medicaid program. Those removals could start April 1st. And additionally, there was a phase out in the enhanced federal support. So that table shows how that enhanced federal support phases out during the course of this year. The decline of the federal support means that states have an extra incentive to remove ineligible people as quickly as possible throughout the course of this year. The Urban Institute estimates that there's about 18 million people as of April 1st ineligible for the Medicaid program, and they estimated where those individuals would go once they are removed from the Medicaid program. More than half will go to employer-sponsored insurance, and what's interesting here is that about half of those individuals already had coverage from an employer. About 3.2 million kids will move to the CHIP program. There's going to be about 1.5 million individuals that go to the ACA exchanges or other coverage. And then there's about 3.8 million people who will, the vast majority of which will be eligible for an employer plan or a heavily subsidized exchange plan, but choose not to enroll. This is one of the really interesting charts to demonstrate the data over the course of the pandemic. So if you can see, the blue bars refer to enrollment in the, the blue bars refer to the unemployment rate. And you can see the unemployment rate spike in April of 2020 and then gradually decline. And the orange line shows the increase in Medicaid and CHIP enrollment over time. You can see that the continuous coverage provisions had people that went back to work and got workplace coverage, but weren't removed from Medicaid. And typically, there's a lot of churn in Medicaid enrollment, people coming off and leaving the program every month. During this period, ineligible people didn't go off the program. So you see that steady increase month after month during the pandemic, which now have resulted in about 20 million ineligible people enrolled in the program. There are several requirements on states to do redeterminations, and Janet and Kelly will talk about some of those. I just want to highlight 4. States must attempt to obtain current contact information for recipients. States must make a good faith effort to contact recipients via different methods if they have their mail returned. States must use ex parte renewal and pre-populated forms, and states must test enrollees for eligibility in each enrollment category. States could begin eligibility reviews and redeterminations on April 1st. There were 5 states, including Arkansas, that started on April 1st. 14 states, including Iowa, began in May. 22 states in June. So the bulk of the states have started their redeterminations. 9 states will begin redeterminations next month. And then we have 1 state, Oregon, which is really taking their time. They don't plan to start redeterminations until October. This slide shows projections from the Urban Institute on the pace of disenrollments. So you could see the blue line is the most gradual redetermination process and what happens with Medicaid enrollment. Black line shows an aggressive disenrollment process. And what's really interesting about reality with the blue line is that nationally, the pace is significantly slower than the most gradual enrollment projections that Urban put out. So even though you're probably hearing about sort of rapid disenrollment for Medicaid, the pace that we're seeing nationally is slower than the most gradual estimates that Urban released. Finally, my last slide. There are legitimate concerns about what happens to people who are removed from Medicaid who are in fact still eligible for the program. So maybe people that don't respond to the state requests for information. It's really crucial that you understand and that the policymakers understand that there are substantial protections in place for people who remain eligible from the Medicaid program but are removed through the redeterminations process. There are 3 main protections. The one is retroactive eligibility. So this basically means that people eligible for Medicaid, they go to the hospital, they go to the doctor, they need services. If they're eligible for Medicaid, they can sign up then and there. Medicaid will pay for their medical services, and in most cases will pay for their services for 3 months prior, so long as they were eligible. The second is hospital presumptive eligibility. So this is an expedited application process where an individual goes into the hospital and the hospital can enroll that individual in Medicaid without verification of their information. And the final one is the appeals process. There's if a recipient is removed, they are entitled to an extensive appeals process, and they can be filed up to 90 days after the enrollees are notified about the termination of their enrollment. With that, I want to turn it over to Janet Mann to talk about the Arkansas experience. Janet, to you. Janet, you're muted.
It's early in Arkansas. Sorry about that. Good morning. Happy to be here. So a little bit about the Arkansas experience and the impact on enrollment. And you can see that when the pandemic began in March of 2020, there were just over 900,000 beneficiaries enrolled in Medicaid. And that was children, age blind and disabled, and our expansion population combined. And over 420,000 of those beneficiaries ended up becoming extended over the course of the pandemic. So we did see a 25% or over 25% growth in enrollment. And after our first 2 months of unwinding, enrollment remains higher than it was in March of 2020. We current enrollment is approximately 1,020,000 people. So, oops. So to talk about the preparation of the unwinding, Arkansas spent approximately 15 months preparing, and we really focused in 3 areas. We focused on our beneficiaries to make sure they knew they needed to respond with the renewal. We wanted to make sure providers and others could help in this effort, and then making sure that we had the staff and the planning and training necessary to handle a huge new workload. And one of the first things we did was we launched an address update hotline, because we know that people, particularly in this population, move frequently, and that they may not have told us if their address has changed over the last 3 years because they weren't required to do so. So in the spring of 22, we began calling beneficiaries. We partnered with one of our current vendors that we do a lot of work with and to do this. And we began calling them, and we focused on who had been extended. And extended means that sometime during the course of the pandemic, they were determined ineligible, but we moved them into an extended category so they would remain in the service, receiving the services of which they used to qualify for. And we ultimately have updated and confirmed addresses for over 170,000 beneficiaries. And that was a large undertaking. We also used some new federal strategies that allowed us to accept verified addresses from our national change of address databases with PASSes, which is a managed care program in the state of Arkansas, our dental managed care companies, and the qualified health plans, which deliver our expansion population health care. And so we used those to check on beneficiaries and addresses. We launched paid and unpaid digital campaigns in 3 phases. First, to update the addresses, and then when the unwinding started, reminding people to respond to their renewals, and now reminding people that the options they have if they lose coverage, which includes federal marketplace and employer-sponsored insurance. And some of these advertising campaigns were very new to DHS. And so we were trying to launch targeted ads in the lobbies of Medicaid providers across our state to get the message out. We actually began sending emails and text and electronic content account alerts to everyone that we could obtain a phone number or an email. We continue to do that now. We also expanded our outreach by working with providers and stakeholders and schools and child care centers, libraries, and more to help connect with the beneficiaries. We've met with all these groups repeatedly, and we continue to have a weekly stakeholder call that all providers are invited to. It started with an hour, and we have reduced it to 30 minutes, but we are continuing to do that every week for everyone to be involved if they would like. We also, not just our eligibility staff at DHS is about a little over 800 caseworkers. We added contracted surge support staff of almost 200, and we also involved all of our program staff in our behavioral health and our substance use and our long-term care and our fee-for-service and our primary care programs. So we even went as far as to hand deliver some packets to our clients. We wanted to make sure that we tried to reach them as quickly and as easily as possible. We also have done all of this work in 3 languages, English, Spanish, and then Marshallese for our Marshallese population in Northwest Arkansas. And also the final thing that we did internally was we streamlined our appeals. We are doing electronic notifications because we anticipated with the increase in the workload that there would be an increase in the appeals. So I touched a little bit on our outreach efforts, but I just wanted to emphasize that there's a 30-day requirement to notify beneficiaries of renewals, but for our traditional population in Magi, we do 90 days notices and a 45-day reminder notice before the closure notice. And for long-term care, we do that with 120 days because there's an additional medical benefit along with a financial eligibility. So we'd like to give the additional time period there. So we've really tried to expand the outreach. And so, as I mentioned earlier, we had the time that we launched, we had 420,000 people in our extended categories. And that's who we focused on first because they were at the most risk of losing their coverage. So that's some of the things that we've done. We started early, and we do have some factors impacting our outcomes. CMS has expressed to Arkansas and very publicly that they are very concerned about our procedural terminations. And we were not surprised because of the outreach of the 170,000 beneficiaries and updated addresses, but also because our minimum wage has increased twice during the pandemic time period, and it is $11 an hour now. In addition to that, we have record low unemployment numbers. In April of 23, it was 2.8, and then in May, it has been recorded that it's 2.7%. So of the population of 3 million in our state, most people are working in some capacity. And then just for ongoing normal course of operations that we are resuming, we do have a historic number of 20 to 30,000 disenrollments every month prior to the pandemic. And we are seeing that again on our regular renewals in the past couple of months. So here are the numbers, our outcomes so far. We have had 2 months, April 30th and May 31st, of disenrollments, and we have renewed others also. So 101,000 renewals have occurred in addition to 140,000 combined disenrollments. And we anticipate that those disenrollments will continue for the next couple of months. So Arkansas sits in a unique position. The state legislature in 2021 passed a state law that was triggered by the bill passed in late 22 in December that then caused us to unwind in 6 months. So while we are unwinding over the course of 6 months, we will do our regular renewals, normal course of business. So we're focusing on that extended population first, which is why we were not surprised that we saw high numbers in the first 2 months. And I think for the additional 2 months coming, we will see the same alignment of numbers or the same range, because we are focusing on those that were in the extended category that were determined ineligible sometime during the pandemic, but we could not disenroll them due to the continuous eligibility requirement. And our remaining unwinding. So we will complete our extended renewals by the end of September, and we will have a report that's due to the legislature at that time on all of our unwinding procedures and results. We are submitting the monthly report that every state's required to submit to CMS on our renewal efforts, and that is on our website, and we send it every month to CMS. And then we will continue with our regular renewals and our appeals process. And so if people do lose coverage, we have been messaging that we do have several options for retro eligibility of 30 or 90 days, depending on the category of assistance. And they can appeal if they feel that they lost coverage in error. But if they are over the income, they can apply for coverage on the marketplace above the extended population or expansion population, excuse me. So we are watching it closely. We know that mistakes will be made, and we will reinstate and recover those eligibility requirements as we encounter them. And I think I'll hand it to Kelly now to talk about Iowa.
Thank you, Janet. And I think this is really interesting because the demographics of our respective states are similar, right? And we definitely have governors who have been paying incredibly close attention with a real laser focus on what the future of our program needs to look like. So this is going to be a really similar story, I think, for Iowa. We are a similarly populated state of about 3.1 million. We have slightly less Medicaid membership, and Janet and I have spent a bit of time talking about that. You know, the dynamics of our employment base, I think, are a bit different. And so there are more Medicaid members in the state of Arkansas than there are. But nonetheless, what we found ourselves in at the beginning of this exercise is that we really did swell to historic caseload records. So covering just shy of a third of our state's population. And similar to what Arkansas did to prepare for that, we made two kind of strategic and operational decisions at the beginning of the pandemic to override the system. So one, to continue to review our Medicaid membership with regularity. The reason for that was really primarily focused on making sure that we were keeping our workforce crisp in their ability to do this work, knowing that at some point a crushing workload would come. Little did we know it would be this far out, right? From that early on vantage point. I think we thought it would be a much shorter engagement, but nonetheless, this was in the backdrop of some really intensive work around business process redesign in our eligibility determinations. I came into this role in November of 2019, so just a few months before the pandemic hit. We had an incredibly high SNAP error rate in our eligibility determinations. And so we were doing some really intensive work around our workforce, the strategies they use, the data sets they pull to make determinations, and the types of questions that they ask our clients to make sure that those determinations are accurate. And so when we made this decision, we wanted to make sure, like I said, our workforce remained crisp. And to do that, we continued our work, and then we refer to them as a slightly different category, but we call them our COVID override population. So we basically put them into the category by which we would typically see them, but then overrode the system and made a COVID override category of eligibility. That is incredibly helpful because we could see from the outset, and we worked closely with Milliman to project what our disenrollments for ineligibles would be, but we could see that somewhere between, on the low end, 17.4% of our enrollees would be disenrolled when this exercise came. And that equates to the membership that you see on the bottom of this slide. And I'm going to show you what our membership looked like categorically during the course of this exercise. So you can see, unsurprisingly, the spaces where our membership increased in our expansion population. I should have started with the fact that Iowa is also an expanded coverage state as well as a managed care state, similarly situated to Arkansas. That we saw, look at our pregnant women's category, three below. This was actually kind of a helpful exercise because meanwhile, the state legislature was contemplating whether or not we should expand coverage beyond 2 months postpartum. And so we were able to see what women were consuming during the course of their continuous coverage. And I think it's changed the landscape of this policy conversation quite considerably. We can see that they're using most notably substance use and behavioral health services. And so we're thinking about how to craft different coverage lines that might help with some of the issues that we see in that population, but perhaps not through a strategy of extended coverage to 12 months in the same way that maybe we were thinking about it pre-pandemic. The CHIP coverage, I think you can see here at the very bottom of this slide, that is the space now as we go through this exercise where we're seeing pretty significant growth. And I think as Janet indicated, right, that's not surprising to us either. We see children moving into that coverage line now in a full exercise in a way that we would see our kind of single adult caseload in the expansion population moving into the marketplace sector. Oops, there we go. So also similar to the approach that Arkansas took, we really did spend more than a year with really vigorous and now continued efforts to make sure that we're openly communicating with all of the stakeholders, really anticipating that, you know, it just takes one case that ends in a gap or, you know, kind of a critical incident that could unravel all of this really thoughtful work that we've now been doing for years. And so making sure, you know, we do, as Brian laid out, we want to make sure that this program is here to serve the Iowans that need the program. So really focusing on the already known and eligible population, publishing that information. I'm going to show you here in just a second what we've done with a visual dashboard that is in near real time. We thought this was important for the press, for associations and other kind of stakeholder groups that are in and around our supporting Medicaid members. We also thought it was important for legislators, knowing that they would be on the receiving end of constituent calls from constituents who found themselves ineligible while kind of at a point of service, maybe the pharmacy or at a doctor's office appointment. We did all of the same types of things that Janet mentioned in Arkansas, obviously texting campaigns, working with our managed care organizations, and lots of social media and advertising type information. One of the things that we found to be most effective, and this is something that might be kind of unique in the landscape of how our members consume, but you know, Iowa is a very rural state, I guess not dissimilar to Arkansas either, but we do have a very large grocery chain called Hy-Vee. It's in every small town in Iowa. So we spend a lot of time talking with Hy-Vee as they tend to be kind of a trusted ambassador of communication on the ground level in rural communities and equipping them and others similarly situated to them to ensure that they had information around, you know, what our paperwork was going to look like, and the importance of responding should a member think that they remain eligible. We have a large refugee population, so we have also done translation in 3 languages, French being the main of our refugee population, but we have others as well. Okay, so I mentioned our dashboard. This is obviously a screenshot. It's hard for me to pull the dashboard into a Zoom. It messes with bandwidth, but you can go onto our website. We publish dashboards in a variety of our programmatic areas. It's very important to us that we be transparent, and we had definitely an understanding from, of course, the governor and the legislature that we be showing this information and give regular updates. So this was one of the tools that we built out early on that we could be able to point to individuals who had questions about what was happening in their communities. And so you can see what is shown on the kind of the main page, but you can drill down deeper into each of these categories. And it's really proven to be a very, very nice tool. We do this for other things, as I mentioned, in our agency. And so it's something that has been really helpful. It's also been a helpful management tool as we have been meeting on a monthly and then every 2 weeks and now weekly basis, kind of in a command center structure, to make sure that we understand what's happening in real time, that we're able to triage issues that emerge. For example, we had very, very early on, as we started to send out those early notice forms back in March, we had a couple of major health systems, one being our University of Iowa health system, send out through their MyChart capabilities that all of their members were going to be disenrolled. That was obviously inaccurate. And so, but we could see it in real time. We saw it through our call lines, and we were able to have a command center type structure that quickly triaged that, got the accurate communication back out, and averted a kind of a near crisis of constituent calls or panic among members. And unfortunately, they serve a large number of people in our long-term services and support sports categories, and so they weren't going to be disenrolled. So it was something that was a mistake on a large provider's part. But again, I think our structure really helped us find that information and respond quickly. So as I mentioned, we worked with Milliman to project out what we would see in the early portion of our kind of first quarter of our disenrollment efforts, and it's playing out, I think, exactly as we expected, similar to Arkansas. So of those renewal forms, you can see in this kind of third line, I'm about to show you another slide that will drill down on this a bit deeper. We're seeing about 40%, right? Roughly 40% of those individuals will roll off in this month of June. And that's because, as I'm about to show you, they're otherwise covered. So here, this is a rolling dashboard, and again, a screenshot in real time. One of the things that I think has been a bit tricky, because the language that we use, and y'all might actually have some questions around this, the language that we use can be a bit confusing. Because we have different categories of kind of where a member might sit in the trajectory of this work, and they're going to flip to different categories from projected to actual. And so we've done a lot of work with our legislative staffers and again, those other associations to make sure that they're educated on the language that we're using as well. So as I mentioned, we could see from the outset, and it's playing out in real time, that 80% of the individuals that are deemed ineligible are ineligible really because they are over income and have employer-based insurance at this moment. Because we front-loaded this work, we're going to see that number kind of fall off a bit, but you can still see that we're sitting at right at a third for individuals in these outset months. So really remaining high on that dual coverage line, which is exactly as we projected, and I think playing out in a way that we would expect, knowing what we know around continuous eligibility and the clear information we saw in our systems. Okay, so this is kind of a recap of what we know, but also peppered in some kind of philosophy, kind of a philosophy of how we've guided this work in Iowa. So we do continue, as Janet mentioned, to be under a microscopic lens of CMS. We are also on one of the watch list states that CMS is not happy with exactly how many members we have deemed ineligible. And so we expect that will come with continued questions. We also have continued to see throughout the entirety of this effort unclear and sometimes shifting guidance from our federal partners on what they see as acceptable practice. So very late in the game, they changed some rules and regulations around what categories we were able to shift within to still meet continuous coverage criteria. And that has been incredibly hard. It's a boomerang effect for our staff. And frankly, seems unwarranted given what Brian laid out in the stopgaps that exist in this program already with presumptive eligibility and other categories, as well as the appeal structure that Janet went into, right? You know, you have to remember that we have a very robust appeals process at the state level. Our process is a space on the appeal side that we have really spent a lot of time making sure we have enough staff and attention. I see that work in real time as well. It's handled in a different area of the agency, and we contract out some of the ALJ work. But nonetheless, that coverage is suspended while individuals are in that process. And so there are no shortage of stopgaps to make sure that these determinations are handled accurately and that members don't lose coverage if indeed they are truly eligible. We also really philosophically believe that individuals have agency and decision-making, and it is incumbent on them to do this work and send it back to us accurately and completely to remain eligible. We believe that fundamentally. And for those individuals who might need some assistance in that process, we've deployed navigators and others to help them. And we believe that is a part of the process as well. But we are actively engaged in making sure that we really promote agency, self-sufficiency, and accountability within this program. And then I wanted to note this, and Janet, I'm actually kind of curious if we, through the dialogue, hear a little bit about this from Arkansas too, but we have also had a fair number of individuals, family members through our state recovery process who are pretty angry that their loved one was held in our program, and they now owe money back to the state for that eligibility process. You know, we do matching and disenroll deceased individuals as quickly as possible, but I think it was quite a surprise to some family members that their loved one was even in our system to begin with. And so that's been kind of a part of the process that has been a bit challenging, and I think will continue to be as we work our way through our disenrollment plan.
Hey, Kelly, thank you so much for that.
Absolutely.
You and Janet, exceptional presentations, great information, a lot of statistics and data, and you already answered some of the questions that we've gotten in. If folks have additional questions, please send them. I want to start with the efforts that Arkansas and Iowa both took during public health emergency to evaluate eligibility. And in Arkansas, you deemed individuals who you, through your review, strongly felt were not eligible as it extended eligibles. And I think you said they were COVID overrides in Iowa, Kelly. But can you sort of talk about, so you did this work and now you're doing redeterminations, and you have prioritized the redeterminations with the individuals that you have very good reason to suspect are no longer eligible. Can you talk about the importance of that and how, you know, starting with the individuals who are the least likely to still be eligible sort of affects the overall data that's coming out?
Sure, I'll start and then hand it to Kelly. So in Arkansas, with covering almost 1 in 3 Arkansans, and we have finite resources. So our approach was we really wanted to right size the roles. We really wanted to be able to deliver the care needed for the most vulnerable of the population in the state of Arkansas, the children, the age blind and disabled, and who needed that assistance. So by continuing to do our work during the course of the pandemic with eligibility in identifying potential ineligibles and putting them in a category, we could do our redetermination process and go through that. And our goal, at the end of all of this is to right size our roles so that we can do adequate forecasting, to have adequate reporting, and then have the resources to serve those beneficiaries as effectively and efficiently as possible.
I think that's exactly right. Same story in Iowa. It was absolutely about leveraging the information we already had on hand, knowing that we would need to duplicate the work essentially, but kind of not from ground zero. So that was a staffing and operational consideration, but absolutely, to echo what Janet said, it's around budget certainty and projecting out, coming into the pandemic, we had a shortfall in the Medicaid program in 2019. That enhanced FMAP helped us avert that shortfall, but we have one coming in 2025 for fiscal year 2025, which is next session. And so really making sure, to Janet's point, that we have budget certainty and can really have solid caseload projections heading into that session is incredibly important given the context of the other budgetary decisions that members will ultimately be making.
Yeah, I mean, it seems like just a basic good government practice to do what your two states did during the public health emergency on eligibility. Do you have a sense of how, do either of you have a sense of how many other states did those reviews during the course of the public health emergency and were really prepared for redeterminations?
I don't have a number. I know it's a mixture of some states. But I honestly have to admit, I've been focused on getting our eligibility redeterminations done and trying to stay on top of the ever-changing guidance from CMS, as Kelly alluded to, that I really don't know.
I don't know that I have a number exactly either, but I do know, one of the context, and certainly for those who are attending today's discussion to kind of understand in their respective states is what staffing looks like. So we've remained fairly stable and augmented, where appropriate, as Janet mentioned. There are some states, though, that are sitting in their eligibility determination section of the agency at 50 or 60% vacancies. And so that's an operational challenge that now comes at historic caseload levels, right? So it is kind of a perfect storm of events. And if your eligibility section is also doing other types of determinations, which ours is, right? And I think Janet's is as well. That it's also coming at a time when there's a renewed focus, and rightfully so, on SNAP determinations and other lines of work at the federal level.
Hey, so Kelly, I have two more questions, and then I'm gonna go to Gary. I was interested by what you said, that many people enrolled don't seem to know that they are enrolled in the program. And it sort of makes sense. People, get enrolled in Medicaid maybe early in 2020, and then they get a job, they have employer coverage. They don't realize that the government is still making a payment to the insurance company that the government's contracted with. The individual doesn't have any financial liability, so doesn't really have an incentive to know what's going on there. I think one of the criticisms that some states have gotten unfairly is around this non-response rate. So I'd like to just talk about that for a second. So if people have other coverage, if they have employer coverage, and if they don't see much value from the program, it doesn't seem like there's a lot of sense for that individual to fill out the response form. They are already covered in another program, and filling out the response form can take time. So I'd like you really to focus on, the individuals who are being removed, the other coverage that they have, and sort of the rational piece of not responding if you have other coverage.
I mean, absolutely. It makes sense. I mean, I would say if I don't need it and I get a piece of mail, and remember, this is real mail, right? So, which, I think folks are thinking, I don't need this and I don't understand why I would be getting it. And so the kind of human behavior aspect of this is, again, playing out exactly as we, I think, would have predicted. I think the rub here is that CMS does not see it that way. And so really is expecting us to take 3, 4, or sometimes more rounds of contacts to make sure that that is the case. And so we're really pushing pretty hard, I know Janet is as well, to show the data points that we have and to let that be enough. And if we make a mistake, because inevitably these are huge processes, and we will, that there are plenty of stopgaps, as you laid out, that ensure that we will retro coverage if an individual has a healthcare event that needs to be covered and they were in fact eligible.
Yeah, I would just echo, there are several touch points, and even there were in normal operations, there were several touch points prior to the pandemic of mail outs and phone calls, county offices, ways to contact beneficiaries with case workers throughout our respective states and across the country. But in addition to that, lots of states added emails and texts and different modalities to contact them during the pandemic and post-pandemic. But also, one important feature of the bill that was signed by Congress, not signed, but passed by Congress and signed by President Biden, that ended the public health emergency in December, was they added the extra modality. So normal course of operations, if you got returned mail, that could be a reason that you closed them. And now you have to take an extra step to make sure you use a different modality, be it a telephone call, be it text, email, or some different type of point of contact before you close that. So they added an extra touch point when most states already had 2 to 3. And when you're doing mailings at 120 days and 90 days, and then even into, closer 40 and 30 days, it's human nature. I've gotten a piece of mail that doesn't apply to me anymore. We're going to throw it away. Did you get an email? Did you get a text? Let me unsubscribe, or let me do something with that. So I think the states have responded, but then with the added modality adds another touch point. And I think CMS expected everyone to stay on the rolls, and a lot of states don't anticipate that at all.
So the state of Florida told me, of the individuals that have not responded to their requests, that most of them have not used any Medicaid services in the previous year. Now, probably a lot of that is people are on employer coverage and not using Medicaid. Do you have any sense in your two states, or are you looking into the number of people that have been enrolled that have not used any Medicaid services in the past year?
Arkansas is doing the analysis. We're also at the end of the year, like most states that have a 6/30 year end. So we're doing the analysis to try to see who in the past 12 to 18 months utilized the services of Medicaid, be it fee for service or a managed care program. And so we don't have any definitive results yet, but I'm anxiously waiting. And then going forward, we're trying to forecast the cost avoidance of removing them from the rolls, but also the change in the FMAP will be factored into that also.
I think it's a similar position that I was in. So we did some analysis by coverage lines throughout the pandemic. As I mentioned, like a pregnant women's category, for example, it was incredibly low, actually surprisingly low, frankly, but I think when you think about it, it makes sense. I mean, we are also the public health agency, and we saw historic lows in just healthcare consumption generally during the pandemic, right? I mean, healthcare itself has kind of fundamentally changed, and we have not fully recovered to what pre-pandemic levels of consumption were. So, so that analysis is kind of peppered into our incident command structure stand-up meetings. Again, I think, as right now, we can see that individuals are duly insured, but as we get in these out months, it will change, right? The population is going to shift. And so we're really trying to make sure that we have a better line of sight into individuals. So we're not disenrolling individuals who are in active cancer treatment, right? And we're working around as much as possible. That's, I think, the human right thing to do. But also we know that there's a drumbeat of continuous, I think CMS did expect all members to stay on, and we want to make sure that we're not falling into that trap narrative. The other piece here that I want to make sure resonates beyond, for that single adult population, we too are back to pre-pandemic unemployment rates, still kind of working on our labor participation, which is, there's a gap between the two, right? And so we're really doing some intense effort on that population with our workforce agency. But beyond that, right? And when we shift to the marketplace plans right now are running at $8 to $12 on average a month. I mean, that is the amount of subsidies that the federal government have pushed into marketplace plans is pretty incredible. And so in terms of affordability, there really shouldn't be anyone that falls into this true gap.
Thank you for these answers. They're great answers, very informative to both of you, Janet and Kelly. We've heard a lot from the advocacy community and from CMS about how many individuals have been disenrolled, but to quantify this a little bit, as a percentage of your Medicaid population, about how much does this represent?
We're right between, I'm sorry, Janet, go ahead.
No, you go first. Go.
So we will be, when all is said and done, we project somewhere between 17 and 20%.
Okay.
We have now started looking at the numbers prior to the pandemic and disenrolling. We were very cautious to use that national average of 15 to 30%, but we think we are falling in there 15 to 22-ish, right along the same lines as Iowa.
I know we've touched on this, but I think just to boil it down quickly, what are really the three reasons, top two or three reasons why people are being removed? If you had to just give a quick answer.
Income and employment.
Okay.
And then there's going to be a portion because they fail to respond.
Yes.
As well, of course, right? And that's where those due diligence steps come into play.
Mhm.
Three pre-pandemic. Now you add a few more, right? So we're up to 4 or 5, including perhaps like in our state, our very last step that CMS really kind of pushed us towards is in person, a knock on the door, a physical knock on the door. So so there will be that will be the third kind of subcategory, but it's definitely there.
So income, meaning people have income that's too high above eligibility thresholds.
Correct.
Employment means they have a job, they have employer sponsored insurance. And then
Yes.
you have people who aren't responding. But probably a majority of the people that are not responding fit one of those two categories.
You got it, Brian. That's exactly
And when
right.
you send out information, there's this requirement on pre-populated forms. I just want to make it clear sort of how easy it is for the individual to stay enrolled. So the state is giving them a pre-populated form, which has as much information as the state knows about the individual, and asks for some questions on some updates on that information. Can you sort of talk about the pre-populated forms process?
Sure. There's actually a step before the pre-populated form in Arkansas, and I predict it's probably the same in Iowa, where we do ex parte or administrative matching process using data sources from some of our sister agencies within the state of Arkansas, and even some federal partners. And if we can match the MAGI population and use their income to determine them eligible, we send them a letter. We have determined that you are eligible. If this information is wrong, we need you to correct it. And then if it's not a successful data match, then we do send the pre-populated form with the information that we have that's correct, ask them to complete it and send it back in to complete their coverage or their redetermination. So, two areas that we try to track very carefully is the big category is they don't return the renewal form at all, or they returned the pre-populated renewal form, and then we have a follow-up question that they don't answer, because most of those are like, can you send us some additional income information or verification? And they determine that they're not eligible.
Okay, thank you. I'm amazed at the amount of effort that both of you are putting into outreach to the recipients. And I think some of that is obviously because of CMS's attempts to keep individuals on, and through your efforts to try and outreach to them. But can you quantify at all the amount of time and resources you are taking to do this kind of outreach? I mean, I don't think in my day running agencies, we saw that type of effort. It's laudable, but it takes an enormous amount of time and effort to be able to do that when you have navigators and you're going door to door. The taxpayers are paying for this, so it's an enormous amount of effort. Any way to try and quantify that?
I don't know. It's a phenomenal question, Gary, and you're right. We try to leverage those resources for, case managers on the MCO side, where we would already expect them to be going to a visit, and kind of, try as best we can to couple those efforts so that we aren't using more dollars than we need to in this exercise. I mean, our Medicaid director, Liz Matney, holds monthly town halls with both members and providers. So there's, several hours of the evening time on a monthly basis. We meet at 7 a.m. with community providers once a week. We have town halls with other providers on a regularly scheduled basis. And that's just our kind of senior leadership executive team. And so those hours total 10 or more a month.
Yes.
And, to some extent, we have other big projects that are underway, and we leverage our time, but it has been a really kind of heroic level of investment. It's incredibly important to us that our program be there to serve Iowa's most vulnerable populations. That's where our focus needs to be, though. And we are very much forward focused. And so you will continue to hear from us that we are focused on getting back to the core mission of our program, and we will be focusing all of our efforts on that core population.
I think, I think in Arkansas, getting back to normal business operations is critical for morale and long-term focus on the mission. But during the course of the pandemic and during the 15 months of preparation for just unwinding, the amount of effort by 800 caseworkers up to 200 surge support contracted workers, not to mention the IT staff or the communications staff or executive leadership, as Kelly mentioned, with additional meetings and Zooms and all the additional mail outs and touch bases with the provider associations. It is a heroic effort that each agency is taking on, and it's unprecedented. I think to even with going in years past with backlogs on changes in circumstances, or going to ACA at the time and changing to MAGI and creating a backlog and working through that was nothing like this. And it is fundamental that we get the roles to the correct size. It's not a right size as a term, as there's an X number. It's the correct people that are eligible, that need the care for the most vulnerable. That you want children to grow up healthy, to become contributing adults in Arkansas and in the rest of the country. And as people age, to age as gracefully as possible in their home or in the appropriate setting. So it's really trying to get those roles to where we can use our finite resources to the best of our abilities.
Hey, so we're at time. I'm going to close with one thought and then one final question for each of you. First, Janet and Kelly, thank you so much for participating and also for what what you're doing with your positions. I think Iowa and Arkansas have both done really admirable jobs in trying to remove the ineligible enrollees, many of whom have been ineligible for years, preserve resources for those who are eligible and need the Medicaid program, preserve state resources for other priorities, and reduce misspending from federal taxpayers as well that could be used for a variety of other purposes. Just to close, the scope of the problem, we have about 20 million people nationally on Medicaid as of April 1st who are not eligible. It's about 20% on average in states of people on Medicaid who aren't eligible for the program. Some states have acted and targeted the redetermination efforts on individuals that are not likely to meet the requirements. There's been some concern that's been raised. CMS has started to reflect some of this concern. There's been stories around CMS putting forward corrective action plans for states, potentially raising the issue of civil monetary penalties for states. Is there anything that you can say on the mitigation plans, whether CMS has been in touch with your states on mitigation plans and how you respond? And then we'll let each of you answer that and take a few seconds to close as well.
So Arkansas did have a mitigation plan for ex parte renewals for long-term services and supports. We were able to make some system changes very quickly and have it in place on April 1. So we did not have to do any additional work on the mitigation plan. Arkansas is not currently under a corrective action plan or having any ongoing discussions about a corrective action plan with CMS. We do continue our dialogue with CMS. They've been vocal about their concern with our state statute of 6 months. We have been very open and ongoing with that dialogue of this is what we've done, this is what we've adopted. We've tried to look at everything they've presented with a lens of can we do it, can we not do it? One of the things that we are very cautious in Arkansas is because we started early, I can't change in the middle of the redetermination process because it would be seen as unfair to the previous beneficiaries with a different set of rules. So we're very cautious on that, but we do continue a good open dialogue with CMS on all of this.
So
Kelly?
I think we also had a mitigation plan. We were not able to do technology changes quite as fast as Arkansas. And that's partly because our eligibility system is undergoing a modernization project and it just didn't fit. So that knock on the door was part of our mitigation strategy there. But we, I think in a similar space, are not having ongoing discussions around corrective action plan at this point in time. I mean, for us, the key is always going to be in the data, right? And so we've had a plan from the outset, the dashboards, this kind of real-time information, very clear, matching over to the insurance commission, and then this active dialogue with stakeholders to make sure that we're not missing anything anecdotal. We always know those anecdotes can pop up just as much as data points, has been a key part of our strategy and will continue to be. So our stand-up, once a week meetings, not dissimilar, frankly, to the way we approached our COVID response. Those were daily, twice daily, but similar structure, right? Where we're going through what's happening in real time and then pivoting different data points and questions that we have about what the data is telling us is going to be our strategy in response to CMS. Right now, we're not seeing anything that would give us pause or would warrant a corrective action plan. And so at the point in time we see something, we would pivot our process, and we want to have an open dialogue. We're committed to our program and serving Iowans. And so right now, we feel confident in our strategy and continue to be, really focused on it so that it will remain throughout this endeavor. I should have mentioned our caseloads, right, for our eligibility workers, to kind of Gary's point about quantifying, they're double, right? They're double the amount we see on a monthly basis. And so it is a heroic effort on all sides. And so making sure we're staying on top of that data is absolutely paramount.
Thank you, Kelly. Thank you, Janet. Thank you to all the participants. We got some questions that we weren't able to get to. We will try to get you some written responses with answers to those. And for more information about this issue, as well as all important health policy information, go to Paragon's website, paragoninstitute.org. Thank you, everybody. Have a great rest of your day.
Thank you. Bye-bye.
Thank you so much.